Hello and welcome to this ENT session, guys. Hello and welcome to this very important session of ENT. So as you know already that this is going to be the recall session of ENT for the exam that was held just few days back, the FMGE exam. This time, usually we had a lot of ENT questions and not very easy ones, some of them are straightforward questions, some not very easy ones. So let's check the answers. I hope you guys are ready. So question number 1, it says a fishbone stuck in piriform sinus, also called piriform fossa, which nerve is likely damaged? Is it internal branch of superior laryngeal nerve, external branch of superior laryngeal nerve, glossopharyngeal nerve, or recurrent laryngeal nerve? And the correct answer is internal branch of superior laryngeal nerve. This is discussed in lectures almost all the time. Now, if you notice this one, the first image is an actual larynx of a cadaver. Now, this tube-like thing is the larynx, and on both the side of the larynx, this area which I am putting across is the piriform fossa. In the second image, which is a laryngoscopic image, this is your larynx. This is your larynx, and on either side, these are the piriform fossa. This is the piriform fossa. This is the piriform fossa. So, piriform fossa, also called piriform sinus, is the area through which the food that we swallow passes through. And this is a very common site of foreign body. In fact, this is one of the most common site of foreign body in the aerodigestive tracts. Now, on this wall that you see, which I am drawing, or this wall is called the AE fold because it is going from arytenoid to the epiglottis. A is arytenoid, E is epiglottis, aryepiglottic fold. On this piriform fossa site, that is when I draw the arrow on this side, on the second image, on this side of this AE fold, internal laryngeal nerve is passing through. It's running in this just below the mucosa, submucosa. So if there is a foreign body in this area, this nerve is likely to be damaged here. This is the image of inside of the larynx, and that's why the name of the nerve is internal laryngeal nerve. External laryngeal is outside the larynx, as the name tells you. So a nerve which is outside the larynx, external, cannot be damaged due to anything inside the larynx. This is inside the larynx, isn't it? And glossopharyngeal nerve, ninth nerve, has nothing to do with larynx. Glossopharyngeal nerve doesn't even come to this, close to this area, so it cannot be damaged. So internal laryngeal nerve is a correct answer in this case. We go to next question. Which is the narrowest part of adult laryngeal airway? Is it subglottis, glottis, supraglottis, or rama vestibuli? Now, in children, infants, subglottis is the narrowest part. Usually when they ask which is the narrowest part of the larynx, they usually ask infants, and then the answer is subglottis. But this time they have asked which is the narrowest part in adults, and the answer is glottis, B. Glottis is the narrowest part of adult larynx. Now, in the lectures, usually we discuss the infant and adult larynx differences, and these are the 4 common differences that we discuss in the lectures. That adult larynx is lower down, infant is higher up. Adult is tube shape, infant is cone shape. Cone means in infant we draw the cone like this. So obviously this, which is a subglottis, is the narrowest part, but in adult this glottis is the narrowest part, isn't it? This was the correct answer. So straightforward, simple question, this one. And then we go to next question. Now they're shown an image of the surgery. The image was very similar to this, of the removal of maxilla, and they've written removal of maxilla, orbit, palate, ethmoid. What is the procedure? Is it total maxillectomy? Is it medial maxillectomy? Is it ethmoidectomy or cardiac surgery? Now suppose you don't know this answer. Even if you don't know this answer, if you look at this image, the second image especially, you can make out, see, this is the lower lip, this is the nose, you can see the nose is intact, this is the orbit, eye, So between the nose and the eye and the lower lip, something has been removed. And the only structures present in this area is the maxilla. And so maxillectomy has been done. In fact, total maxillectomy has been done in this patient. Right. So the answer is total maxillectomy. In the first image, if you look at the incision line passes like this. This incision is called, I'll give you the name. Now, the first image, as you see, only below the lip there is a window created. This is how we do cardiac surgery. Cardiac surgery is nowadays a very uncommon surgery. It should be done in the past a lot for maxillary diseases. Nowadays, because of endoscopy, nasal endoscopy has become a very common surgery. So cardiac surgery is almost outdated surgery, not completely outdated though, it is done. And this second image is the area surgery showing ethmoidectomy. How ethmoidectomy? If you know the anatomy, ethmoid lies between the eye and the nose. So this is the eye, this is the nasal cavity. Between the two is the location of the ethmoid. So if you are creating an opening here and remove the ethmoid, then it becomes ethmoidectomy, and the incision is called Lynch-Howard incision. Sometimes the surgery is also called Lynch-Howard surgery. It's not important for you to know the name, but the first image in the question, that is total maxillectomy surgery. Right. The next question, that human papillomavirus infection is most strongly associated with of the head and neck cancers. Is it laryngeal carcinoma, nasopharyngeal carcinoma, oropharyngeal carcinoma, or hypopharyngeal carcinoma? Now, if you read your old ENT books, like old means like say 15-20 years old books written, they all said that laryngeal carcinoma and hypopharyngeal carcinoma also have viral etiology, human papillomavirus. But lately, about a decade back, it was very conclusively proven that laryngeal carcinoma and hypopharyngeal carcinoma has no viral etiology, no kind of viral etiology. That is confirmed now. So the answer has to be one of the two, either nasopharyngeal or oropharyngeal. Nasopharyngeal carcinoma is caused by Epstein-Barr virus is a very, very common question they ask you. Most of you know this. So the only left is oropharyngeal carcinoma. And so the answer is C, oropharyngeal carcinoma. So once again, as you can see here, what I just told you, that laryngeal carcinoma has no viral etiology. Nasopharyngeal carcinoma has a is caused by Epstein-Barr virus. Oropharyngeal carcinoma is caused by HPV-16, to be more precise, 16. And hypopharyngeal carcinoma has again no viral etiology, which I told you already. Now, human papillomavirus, is also very notorious for causing laryngeal papilloma. And laryngeal papilloma is seen in children, juvenile age group, but that is caused by HPV 6 and 11. But carcinomas are caused by 16, this one, sometimes some carcinomas are caused by 18 and 23. So HPV 16, 18, 23 are very notorious for causing carcinomas, and 6 and 11 are notorious for causing papillomas. Okay. So in this case, C, oropharyngeal carcinoma is the correct answer. Next one. Question says, the professional singer had post-thyroidectomy, has a thyroidectomy surgery. Post-thyroidectomy cannot raise the pitch, no hoarseness. So only the patient is not able to raise the pitch. So there is a low pitch voice, but there is no hoarseness of voice. It clearly says. So which nerve is likely to be injured? Basically, they are asking you, if the pitch of the patient is gone, which nerve is caused? Now, pitch is controlled by which nerve? Which muscle? Pitch is controlled by cricothyroid muscle. And so, cricothyroid muscle is supplied by external laryngeal branch of the superior laryngeal nerve. And so, this answer, the only muscle supplied by external laryngeal branch of the superior laryngeal nerve is the cricothyroid muscle. And the only function of this muscle in the larynx is pitch. Its cricothyroid muscle is called the main tensor but weak adductor. So the main function is to do tension. It also do mild adduction. But if this nerve is gone or this muscle stops functioning, cricothyroid, then what gets affected in clinical practice is only the pitch. So interestingly, see, this is the second question related to the laryngeal nerve, more or less. The first question we discussed was about internal laryngeal nerve, and now there is another question that is about external laryngeal nerve. So this tells you that laryngeal nerve is a very, very important topic, laryngeal nerve and the muscle. So if you remember in the lectures, when I teach the anatomy of the larynx, and we start with simple anatomy, parts of the larynx, then difference between adult and infant larynx, cartilage of larynx, unpaired cartilage, paired cartilage, and then we come to this part where we discuss the muscles, their functions, their movements, the nerve supply. And I always tell in the lecture that in laryngeal anatomy, this is the only thing they ask you 80% of the time. Rest of the thing you can ignore 80% of the time. See, actually there are 3 questions already about this area, these 2 nerves, and one was about difference between adult and that, which is part of the larynx is narrowest in adult. So somehow related to laryngeal anatomy, they've asked, and clinical aspect of the laryngeal anatomy, they've asked a lot of questions in this one particular paper. And I've noticed in ENT at least that in FMGE exam, they've been doing this pretty regularly, that they pick up one topic and they ask you multiple questions from that particular topic. I still remember that around 2021 is somewhere, from nasopharyngeal carcinoma, in one paper they'd ask 3 questions, straight questions only from nasopharyngeal carcinoma. Last to last year, from juvenile angiofibroma, they'd ask 2 questions in one paper. So this is a pattern that I'm seeing in FMGE exam, that they pick up one topic and they ask multiple questions related to that topic. Already we have discussed 3 topics, 3 questions from the same, related to same thing, almost. So that's what they've been doing, at least in ENT. I can vouch for that. Now, this is what you have to know, that if the recurrent laryngeal nerve is damaged, then the complaint is hoarseness and dyspnea. And the question clearly said no hoarseness, so it cannot be recurrent laryngeal nerve. If the external laryngeal branch of the superior nerve is infected or damaged, then low pitch voice. So this was the complaint of the person, and that's why external laryngeal branch of the superior laryngeal nerve is the correct answer. If internal is gone, then aspiration is the main complaint. And if the vagus is gone, all the nerves stop functioning, then aphonia and aspiration are the complaint. So this is the type of question they've been asking very, very regularly in laryngeal anatomy. They give you the symptom from here and they ask you to pick the nerve, like the question they just asked. And this type of questions are very, very common. In the lecture, what I do is I show you this kind of a chart, that vagus in the larynx has 2 branches, superior laryngeal nerve and recurrent. Superior again divides into internal and external. Recurrent does not have a clear-cut division, so it remains recurrent. So eventually in the larynx, we have 3 nerves, these 3, right? And these are the functions, which I'll not tell you because you know that already. These are the functions of these nerves. And what are the symptoms when which nerve is gone? So just repeat of what I just told you. If internal is gone, the main symptom is aspiration. If external is gone, the main symptom is low pitch voice. If recurrent is gone, either hoarseness or dyspnea. And if superior is gone, this one, then aspiration plus low pitch voice. Right? I'm sure that you remember this and you could have answered this question without any problem. Okay, guys. Next one. So there was an image based question, obviously different image, and it shows an abscess in that marked area. We have made a circle there, and they ask you that there is a abscess here. So name this abscess. Is it post-auricular abscess, zygomatic abscess, Bezold's abscess, Sitley's abscess? Now post-oral is behind pinna. As the name tells you, post-oral abscess is behind the pinna. Bezold's abscess in the sternocleidomastoid muscle. And Sitley's abscess in the posterior belly of digastric muscle. I think you remember this. So this is a zygomatic abscess. This area, this bone, I'm sure you know, is a zygoma. So because the abscess along this zygoma, this part of the zygoma is called the root of the zygoma. Because the abscess is in the root of the zygoma, so the abscess is called zygomatic abscess. Now this image will tell you better. See, look at the 3 important abscesses from the mastoid. Zygomatic abscess is this area, post-oral obviously behind the pinna, and Bezold's is somewhere here. This is how a Bezold's abscess looks like. This is how the Bezold's abscess looks like. Swelling of the Bezold's abscess. Right. Out of the abscesses possible from the mastoid, Basals is the most popular abscess they ask you in the exam. And that's why I'm showing you the image of how the basals abscess looks like. Actually, zygomatic abscess is the least common abscess from the mastoid. Least common, and so ideally the least important MCQ also. But somehow they've asked that question. The least important abscess they've asked this time, zygomatic abscess. But I think there is no problem. If you know the anatomy, that this area has a zygomatic bone, root of the zygoma, the abscess is called zygomatic abscess. Now this is the type of diagram that I draw in the class, and this is the middle ear cleft. So the abscess goes in this area, zygomatic abscess. There is also a Luke abscess in the canal. Sitley's, I told you, is the abscess in the digastric muscle, and basals abscess in SCM. SCM stands for sternocleidomastoid, and behind the pinna is post-auricular abscess. So this kind of images gives you a visual imprint memory, and then you can remember them very easily and nicely, right? Okay, let's go to the next one. Uncinate process is superior. What is the superior attachment of the uncinate process? Now, in my opinion, this question was not warranted. In FMG, for you, if they ask you this question, I don't think this is the right question to ask. It's a very, very tough question. Even in PG, if you ENT PG students, if you ask this question, even they may not be able to answer this question. But clinically, when we do face surgery of the nose called face surgery, this information is very important. And maybe that's why they've asked this question, because during face surgery, you have to be aware of this fact that attachment of the superior part of the uncinate process have multiple attachments. In different people, different attachments possible. It is possible that is attached to lamina papyracea. This is possible. In some people, it attached to the middle turbinate. In some people, it can be attached to the base of the skull. So actually, all the three are possible. That's why D is the correct answer, all of the above in this case. Now, let me show you the image that how it looks like. It will give you an idea. Now, this is one side of the nose with orbit. This round thing is the orbit. Okay, this is the nasal cavity of one side, and below the orbit and lateral to the nose, this is the maxillary sinus. On the lower part of the maxilla, this area is the floor of the maxilla, which is also called the superior alveolus, and the superior alveolus has teeth. You can see the teeth are drawn here very nicely. Okay, this cell that I've tried to draw is actually bulla ethmoidalis. You don't have to know. Okay, now in this orbit, and this is the nose. This blue colored wall that I've drawn is the lamina papyracea. Lamina papyracea means paper-like bone. Lamina papyracea means paper-like bone. It's a very thin bone. It's the weakest bone on the of the orbital wall, and so it's called lamina papyracea. It's like a boundary between the nose and the orbit, eye. Now, this red thing that you see is the uncinate process. This is the uncinate process. So the question is asking about the superior attachment of the uncinate. This is the superior attachment. So look, the three different attachments are possible. In the first image, this red thing is going to skull of the base. So this is the base of the skull. Sometimes in the cribriform plate, there's cribriform plate, it may be attached there. In the second image, you see it is going laterally, turning medially, and is inserting onto this structure, which is the middle turbinate. So this is the middle turbinate, this is the inferior turbinate. Okay, this is the inferior turbinate, this one, and this is the middle turbinate. So you can see it is turning medially and inserting into the middle turbinate. And in the third image, this red thing, you can see it's turning laterally into the lamina papyracea. It's turning in the lamina papyracea. Now, how does it make a difference? I told you that also at your level or even PG level, this question is not a very common question. It's supposed to be a tough question, but in clinical practice, this information is very important. You know why? Because this sinus, which I'm pointing here, this sinus is a frontal sinus, and the frontal sinus is draining through this. This is the ostia of the frontal sinus. This is the ostia of the frontal sinus. This is the ostia of the frontal sinus. Now, depending on where is the attachment of this uncinate process, the drainage of the frontal sinus can happen to different parts. Like in the first two, if you notice, the frontal sinus is draining in this area. In this area, which is like the infundibulum. It's called the infundibulum. I don't think you'll know this term anyways. But in the third image, it's going between the turbinate, middle turbinate and the uncinate process, going here directly into the nasal cavity, in the middle meatus as we call it. So the real difference that happens in the person, depending on where the superior end of the uncinate process attached, is that the frontal sinus in different person can drain into different part of the nose. And this, I told you, can be a significant thing during face surgery. Okay, and that's why this question is a relevant question from the ENT point of view. But I think it's a very tough question to ask. If you have not been able to answer this question, I think it's okay. You shouldn't feel bad about it. History of fall, bleed from ear, investigation of choice. So there is a history of fall, there is a bleeding from the ear. So now history of fall with bleeding from the ear means what? Ear lies in the temporal bone or petrous part of the temporal bone. There is a fracture of the temporal bone or fracture of the petrous part of the temporal bone, only that can cause bleeding. And any bony fracture are best seen on CT scan. I think this was the easiest question out of the lot. Easiest question, I think. Even if you don't know ENT, you can answer this question. Such a simple question, isn't it? Then we go to the next question. Elderly male, high frequency hearing loss worsens in noisy environment. Diagnosis. Now, see, the answer is presbyacusis. Some people say that this kind of a audiogram was also shown. This audiogram, where the graph is going downwards like this, as you can see, is called downward sloping audiogram. Now, downward sloping audiogram can be seen in presbyacusis very, very commonly. I don't know whether this graph was shown or not. Even if it was not shown, in this case, the answer becomes presbyacusis A. Presbyacusis, age-related hearing loss. Elderly people, when they get aged, they have a hearing loss. That's called presbyacusis. Age-related hearing loss is more at high frequency. That hearing loss is more at high frequency, and in the noisy area, it becomes even worse. Now, why cannot Meniere's be the correct answer, or otosclerosis or noise-induced hearing loss? I've written here for you. So, if you notice, presbyacusis is the answer. So, we know that in Meniere's disease, low frequency hearing loss is there. More hearing loss at low frequency. In this patient, it is high frequency. So, it cannot be Meniere's. Now, otosclerosis, the hearing improves in noisy area. In fact, this is a sign called Swart sign. Everybody knows Swart sign in otosclerosis, where the patient hears better in the noisy area. But in this particular, they said the patient's hearing worsens in the noisy area, and so it cannot be otosclerosis. In fact, otosclerosis is more commonly seen in young females, not elderly males don't have otosclerosis that commonly. So even that rules out. And noise-induced hearing loss, usually there is a history of exposure to loud noise. There will be something they'll tell you that the patient has been exposed to loud noise, but there was nothing to suggest that the patient has been exposed to the loud noise. So this cannot be the correct answer. Although in noise-induced hearing loss also, the patient can have high frequency hearing loss. It is possible. But because there was no mention of exposure to the loud noise, so best answer is presbyacusis A, which I told you already. Right. So A is the correct answer. Let's go to the next one. A diabetic male, pain on the face, blackish discoloration, most likely diagnosis. Now, blackish discoloration of the nasal tissue, nasal discharge, I'm sure everybody knows since COVID, it's called mucormycosis. Mucormycosis. Mucormycosis in common terms is also called black fungus. This was such a common term during COVID, as we know, especially the Delta wave of COVID. And that black fungus, the name was given because the tissue becomes black and the discharge of the nose becomes black. If this disease spreads to the eye becomes black. If it goes to the brain, the tissue of the brain becomes black. So black fungus, mucormycosis. And because mucormycosis spreads from the nose to the orbit and then to the brain, nose, orbit, brain, it is also called rhino-orbito-cerebellomucormycosis. So common name is mucormycosis. It can also be called rhino-orbito-cerebral mucormycosis because that's how it spreads from the nose to the orbit to the brain. So C is the correct answer. This was again a straightforward, simple question. I think nobody should have a problem during the exam. Okay, very straightforward. Then, if you cannot pass endotracheal tube, assuming that the patient has dyspnea, difficulty in breathing, and you cannot pass endotracheal tube, usually when there is a trauma on the face, on the nose, you can't pass the endotracheal tube. So which of the following can be used to secure the airway? Because there is dyspnea, so you have to secure the airway. So which of the following can be used? Nasopharyngeal airway, laryngeal mask airway, bronchoscopy, or cricothyroidotomy. Now see, if you cannot pass, the endotracheal tube is usually passed to the nose, sometimes to the mouth or to the nose. If you cannot pass the tube from this area, that means this area, nose and mouth, the face is traumatized or has some problem in the face, because of which you cannot pass the endotracheal tube, so you cannot use the face, right? So nasopharyngeal airway cannot be used because, again, I told you, face area, nose cannot be used, nasopharynx cannot be used. Laryngeal mask also passes from the mouth. You pass the laryngeal mask from the mouth, again you can't use this area, so that is ruled out. Bronchoscope is also passed to the mouth, oral cavity, again this area has a problem, so you can't pass. Cricothyroidotomy is done in the larynx here, in the neck, if you can see my, between the cricoid and the thyroid cartilage. And so this is the only possibility. In this patient, there are two possibilities. Either you can do cricothyroidotomy or simple tracheostomy. So both are correct answers. If tracheostomy is given, actually that is a better answer, tracheostomy. If tracheostomy is not given, you can go for cricothyroidotomy. Both are correct answers. In fact, cricothyroidotomy is a subtype of tracheostomy. Cricothyroidotomy is also called mini tracheostomy, is the other name for cricothyroidotomy. This is a type of tracheostomy. So in such patients whose nose and mouth cannot be used for securing the airway, this area has some problem, either because of big growth or trauma or edema or whatever, then you have to use the larynx and the trachea. So whichever is given the choices. In this case, cricothyroidotomy is the correct answer. I think again, simple question, not a difficult one. Okay. Then next question, a child is irritable, is having poor school performances. On examination, there is a dull retracted tympanic membrane. There is a fluid in the middle ear or effusion. Diagnosis. Now, even if the giveaway here are two things. A, the dull retracted tympanic membrane. If I tell you this one, you straight away know it is serous otitis media. If there is an effusion of fluid in the middle ear, again the likely diagnosis is the same thing, serous otitis media, right? And because of serous otitis media, the child is not able to hear properly. So when the teacher is teaching in the class, the child cannot hear, and that's why the school performance is poor, right? Typically, a patient of serous otitis media, the first thing is the school performance, it goes down drastically. The child was scoring well, doing well in the classes, the test and exams, and suddenly the score is falling down. That means the child is not able to hear in the class. And if you do otoscopic examination, you will see dull retracted tympanic membrane, maybe fluid. And serous otitis media is also called otitis media with effusion. Okay. Now, out of all the types of otitis media, in the exam, this one is the most commonly asked otitis. I tell you in the exam that if they ask you a question on otitis media, there are 5 types of otitis media: acute otitis media, serous, safe CSOM, unsafe CSOM, tuberculosis, and all that. This one is asked almost 50 to 60% of the question of otitis media comes from this question. And the question is very similar to this. They'll give you a history of a child, school-going child. It happens to be a school-going child. The child when starts going school, then that is the time this happens. And typically there is a retracted membrane, maybe there's a fluid inside the middle ear. Now, why is it not ASOM or CSOM or otosclerosis? I've given you. In ASOM, there's pain. Pain is a very significant symptom because acute inflammations causes pain. And there will be bulging tympanic membrane, opposite of retraction. Retraction is tympanic membrane is pulled in. This is bulging. So the findings are opposite in these two cases. That's why it cannot be ASOM. And why not chronic? In chronic otitis media, there is a perforation. Tympanic membrane perforation is a hallmark feature of chronic otitis media. There is no mention of perforation, so it cannot be chronic. And because of perforation, there is ear discharge. In CSOM, whether it is safe CSOM or unsafe CSOM, in tuberculosis of the ear, discharge is a most important symptom. Sometimes there is hearing loss and discharge. Patient ignores the hearing loss, but when ears start discharging otorrhea, that's when they get worried and they come and present to the doctor. So ear discharge is a very important significant symptom in CSOM, which was not mentioned in this particular case. And otosclerosis, I just discussed in one of the questions, has Schwartz sign. Fleming pink blood Schwartz sign is not mentioned. And otosclerosis is seen in females, young females, as we know, not in school-going child. It is never seen in that age group, right? So rest of the choices are very easily ruled out, my dear friend. So like I said, maybe 1 or 2 questions of ENT were difficult, especially the Uncinate process. Rest of them were straightforward, simple question. Even if you can't answer one question out of 15, 16 of ENT questions, so many questions of ENT, so this time it's okay. Most of the questions you could answer, I think, straightforward, simple questions. So it was not a tough paper. I'll not say it was a tough. ENT part was not very tough, but it was not very easy either. Okay, I hope that most of you have answered correctly, and please follow us on YouTube, because we are going to do all the subjects. Till then, God bless you, goodbye, and all the best. Best of luck.